Hi there. Today we're going to talk about kyphoscoliosis. Now, kyphoscoliosis is actually a combination of two different deformities of the thorax. Kyphosis, which is a posterior curvature of the spine, which you probably know better as somebody who has a hump on their back. Scoliosis is a curve to one side, usually appears as an S or a C. Many times we check for scoliosis in younger adults, usually in grade school and high school, to determine if it is occurring, because it's easier to treat when we catch it early. Now, when you put these two things together, and you can see in the photograph here in the middle, you have that C or S kind of curve. This causes a restrictive deformity. So the lungs cannot expand as well as they should. This also shifts the mediastinum in the middle. And as you can see there in letter A, mucus starts to accumulate. And that mucus gets large amounts, and it starts to get thick, and it can grow microorganisms. And as you can see in letter B, we start to develop atelectasis. That is the collapse of the alveoli, and therefore having poor gas exchange. Now, kyphoscoliosis affects about 2% of people in the U.S., mostly young children that are going through growth spurts. Rarely does it develop in adults, but it can. It's usually found in adults if it is a worsening condition from childhood. Kyphoscoliosis, or kyphosis primarily, can develop in adults from degenerative joint conditions in the spine. This is why we tend to see older people who have a hump on their back. That is kyphosis from degenerative spine issues. Now, the curve part, scoliosis, idiopathic scoliosis, meaning we're not sure what causes it, gets classified into three types. Infantile scoliosis, here's where the curvature of the spine develops during the first 3 years of life. Juvenile scoliosis, the curvature occurs between 4 years of age and the onset of adolescence. And then adolescent scoliosis, the spine curvature develops after the age of 10. Now, some risk factors include the location of the scoliosis. If the curve is in the middle to the lower part of the spine, it's less likely to progress than if it was in the upper portion of the spine. Height. Taller people tend to have a greater chance of the curve progressing. Spinal problems at birth. Children who have scoliosis at birth, we call it congenital scoliosis, have a greater risk of worsening of the curve as they grow. So how do we diagnose it? Well, scoliosis is diagnosed primarily through medical history, physical exam, x-rays, and curve measurement if the scoliosis is found. Clinically, scoliosis is commonly defined according to the factors related to the curvature. the shape of the curve, whether it is an S shape or a C shape, the location of the curve, is it higher in the thoracic vertebrae or is it lower into the lumbar vertebrae? The direction of the curve, is it a left or a right curve? And the angle of the curve. Now the angle of the curve, this is a photograph of a patient with kyphoscoliosis on the left, and in B, this is a rendering that shows what we call the Cobb angle. We look to see if the curvature of the degree is 10 degrees or more. Cobb angles only reflect curvature on a single plane, so it may not identify the severity of the scoliosis, especially if the patient has vertebral rotation and a three-dimensional spine deformity. On the physical exam, your patient may have digital clubbing. You learned about clubbing in your patient assessment course. Peripheral edema and venous distension. This can be from the heart being compressed by the chest. Cough and sputum production. Again, because of the atelectasis, because of not being able to move air correctly from a restrictive disorder, we're going to get more mucus, and this is going to cause more of a cough. Now, the chest assessment findings, you're probably going to see obvious thoracic deformity. Usually, this will become an issue for your patient in severe cases. Mild scoliosis or mild kyphoscoliosis is not going to impair the respiratory system as much as a severe. You're going to see a tracheal shift. You're going to find increased tactile and vocal fremitus. Dull percussion notes when you do indirect percussion. Bronchial breath sounds. Whispered pectoriloquy. And possibly crackles and wheezes on auscultation. Some laboratory findings in severe and or late kyphoscoliosis usually come from the patient being chronically hypoxemic. So this is going to manifest as a increased hematocrit and hemoglobin from polycythemia. They may have hypochloremia and hypernatremia. Chest X-ray is going to show some blunting and thoracic deformities. The radiologic finding is really going to be what's going to help you. We said already mediastinal shifts, increased opacity of the lung, atelectasis from the compression of the lung, and possibly an enlarged heart, cor pulmonale from right-sided heart failure. This is an X-ray of a severe kyphoscoliosis patient in a 14-year-old male. You can see the deformity of the lungs. You can see the severe deformity of the spine. So the patient cannot take in a deep breath. That is the restrictive part of this disease. General management of scoliosis and kyphoscoliosis. The treatment depends on the degree of the curve and what caused the scoliosis. We also look at how much more growing is the patient expected to do? In most cases, less than 20 degrees, the degree of abnormal spine curvature is relatively small and requires only observation to ensure that the curve does not worsen. In young children who are still growing, observation checkups are usually scheduled in 3 to 6 month intervals. Now, if the degree is greater than 20 degrees, usually 25 to 30, in a child who is still growing, we may use treatment options such as surgery, spinal fusion, or rod instrumentation. You may also see the patients wearing back braces to try to straighten out the curve. This is an X-ray of a patient that was treated with a Harrington rod for scoliosis. So you can see the metal rod in the back. Now you will see that the ribs and such are still deformed from the curvature, but by straightening out the back, it has allowed more lung volume and less of a restrictive disorder. Treating these patients usually requires some type of oxygen therapy protocol, trying to make sure that we are keeping them oxygenated above a 92% saturation. Bronchopulmonary hygiene, we want to make sure that we are keeping secretions thinned and moving into larger airways. And lung expansion protocols. We want them to be taking as deep a breaths as they can take to keep things open, to keep those secretions moving, and to improve their oxygenation.